Yeah.
That's
really cool.
Oh, sure. She's the different country.
More about
Here's the part I need to tell you, Dr. Overline, is that Steve Chen emailed us at 12-something in the middle of the night saying, there's this really important.
Yeah, that's awesome.
Federally.
Yeah, it's tomorrow. In California,
There are
but
a couple of, quite a few.
most of my
So,
around California, I have a background in public health.
so we're just going to start right on time. So that's now. Yes.
Yeah, so
and just with how the whole, it's such a gamble when it comes to it, but just kind of focus more on the bigger picture.
So I think it,
I guess I'm sure from California, our team is sort of all my other self and my interviews stay pretty local. So we're both fine in California, and then one other team member. Yeah, that's where the past 4 years have been, and maybe the next 4. But very small.
Okay, everybody, can I get everybody to please sit down? Because we have a very full agenda today. An amazing meeting. Gentlemen. It's great to see such lively conversation, and we have to pick it up later. So, welcome everybody to the first University Best Practice Los Angeles of the year. My name's Dr. Carol Peden. I'm a Director of Innovation at Keck Medicine of USC in East Los Angeles. So it's nice to come over to the west side. We have a very full agenda today and lots of amazing speakers, so we're going to try and keep it on time. And as you know, we're shortening these meetings to, or the number of these meetings, and having them slightly longer, so we'll be having 5 meetings throughout the year this year, really dedicated to reducing the incidence of myocardial infarction and stroke in Los Angeles County, which, as you know, is bigger than a lot of states. So, without further ado, let me welcome Hattie to take the meeting forward.
It's so wonderful to have Dr. Carol Peden back with us. She is an international lecturer for many countries with the Institute for Health Improvement, Don Berwick's group. We want to also emphasize that we're working not just on heart attack and stroke prevention and better management, but also diabetes, as these are such important comorbidities. I wanted to first just say how amazing it is to see the collective minds at the table. You all don't know each other as well as I would like you to. By the end of this meeting, you will know each other so much better. But there's not a person in this room that is not leading amazing work. And together, we can do so much more to implement the best practices to prevent those heart attacks, strokes, amputations, blindness that are creating unnecessary, preventable disability and death. So I come at this from the standpoint of not only a patient advocate and a family advocate, but also as a person who has trained extensively in driving policy change with data and collaboration. So I'm thrilled to have so many medical directors and leaders with us from around the world. I have to say, I am so excited about this new decade and this new format that we're going into, where we're having the same number of programming hours, that's 20 hours a year, but we're consolidating it into 5 meetings so that we can have this wonderful opportunity to do what I call cross-pollination in policy, which is so important. So we have Dr. Mike Dolan, who came in through a blizzard in Wisconsin, flew in last night, and is flying out immediately after this meeting. Amazing dedication. We have so many exciting things going on, and people will start trickling in. We are doing things beyond what we're doing in Los Angeles. We're working statewide and increasingly nationally. So I want to say that as I wish you a happy new year and a happy new decade, I can't tell you how much it meant to me that the first email I read in the new work year on January 2nd, 9:03 a.m., pops in an email from the new physician leader for the National Million Hearts Program of the CDC, saying, hey, I'd like to meet with you and learn more about the Right Care Initiative. I will be in California on tomorrow. And so anyway, I've shifted everything around to spend the day with him and meeting a lot of leaders. So what we want to all be thinking about, and I know we all believe that technology can help us to scale up our work. I am not the person to figure out the technology, but I think that in our collective mind here, we will make headway on that issue this year, because increasingly our work is going to need to extend beyond our regional meetings. So, you know, can we do a collaborative with Gunderson in Wisconsin, one of the top performing health systems in the nation and possibly the world? So awesome to have such a leader with us. The second great email that I got this year was first thing Monday morning on the 6th, which was the head of cardiovascular for CDC inviting me to become a founding member of a new national roundtable on hypertension. So many of us might be involved with that. I don't know who else is going to be on there. I frankly haven't had the time to read a lot about it. But I just want to say that we've been doing this now for 12 years, and it's building and it's building, and people are getting to know each other. And as people take jobs in other states and other countries, there's more demand to figure out how to extend our reach. And the tricky dynamic is that it's by being in this room together, spending time getting to know each other, that we can really do problem solving. And we have with us today Dr. John Overtveit, who's going to join me at the podium in just a moment. He visits us from Sweden every year from the Karolinska Institute. He has over 800 publications, 6 books, translated into I think 7 languages. It's written in your bios here. He is an international phenom, and we are so lucky to have these few hours with him. We don't know the next time we'll see him. I'm trying to entice him to come to our Stanford meeting in a couple of weeks. So John, could you join me at the podium, please?
Yes.
He's going to run a really tight ship today, and we're going to see how this international phenom in implementation science runs a meeting. So bless you for being here, and thanks everybody. Hang on to your hats, it's going to be a wild ride.
Thank you very much, Hattie. I don't know whether to thank you or say I'll get you later about all of that. But certainly in Sweden, we tend to downplay. We don't have introductions like that, and it's quite embarrassing. But anyway, thank you so much, and thank you so much for inviting me. And I also want to acknowledge Hattie and her team, the enormous amount of work, and Bob later on also will be saying hello, and the 3 co-chairs to this particular division of the University Best Practice that we'll hear from later. Would you like to have a look at your timetables? Because that's what's preoccupying me And this is a new format for this particular meeting, where we're going to be covering quite a lot of ground in a longer meeting. And we want it to be varied in some degree of interaction. And in particular, we would like you to be thinking about, during the presentations, about what of this most applies to my organisation and would make the biggest difference to the patients that we serve. And the handout with those questions that I passed around is to encourage you to be thinking about those questions, about how it applies to your organisation and populations for each presentation and the items that colleagues will be covering. If you look at the timetable, you can see why Hattie invited someone who lives overseas and probably won't see many of you again and doesn't work in the area to lead this meeting, because it needs someone who's going to be unpopular without being rude and being assertive about the timetable. So I'm very sorry, but the speakers, I'm going to give you a 10-minute waving this, and everyone will see me waving this, and then there'll be a 5-minute. And the reason is that we want to leave at least 10 minutes, if not 15, before the end of each session for questions and comments, and also to share from your organisational system items that may be relevant to that. The other part where we want you to share your thinking and ideas about application will be towards the end of the timetable. We're going to try and get in 20-25 minutes at the end of the day for 3 small groups that will be organised around each speaker's items that they cover. And then we'll try and get a short report back from each of those groups. That's the plan, and then life happens. So I'll try and keep to that, but we have to also have some flexibility. So I'll grant you that, Hattie.
And we're a little ahead of time, so you have 6 minutes if you want them.
No. What I want is to hear from the speakers, because these are special people. And I think already they're perhaps rethinking their slide decks when they say, yeah, actually I need to leave a few minutes for questions and answers, and I'm sorry about that. But I don't know, are we going to are the slides going to be available, that full set, to everyone?
All of our slides are posted on our website and all of the videos, so.
Well, a big thanks to the presenters for that as well. That's really something. Okay, thank you, Hattie. So, the other quick introductory thing I want to say is that March the 12th will be focusing on diabetes care and heart failure best practices at Cedars, and that will be here at Rand. So that's going to be an interesting session. And then May the 21st, women's heart health, be particularly interesting. So do tell your colleagues and spread the word about those. You will get mailings and hear more about that. So, Hattie, did you need to say anything about statewide right care initiatives, or have you done enough?
I've said enough.
All right, okay. So, without further ado, my suggestion is that we go straight to Michael Doolan. And Bob, you know Michael. Would you like to introduce Michael?
You bet.
And we're honoured that you made this trip such a long way in this weather without knowing if you're going to be able to get back with airports and systems both. So Bob, over to you.
Thanks, John, and thank you for assertively facilitating today. So, I've had the pleasure of working with and knowing Dr. Dolan for about, I guess, 9 years this month. When I landed in La Crosse, I spent a few years working side by side. We had an open space media executive area there, so we were always just one cube or two away from each other. And whether it was working through a week of operations and clinical performance reviews, or whether it was convincing our local community board that helps what the vision of a health system was among the executive team, which happened to include things like dairy digesters and end-of-life training programs and child abuse detection programs, so unusual things. I tell you, I've never met a harder working, more effective physician. And that leads all the way up to yesterday when Dr. Dolan got up, chaired the chairs of the clinic's meeting, spent a few hours in clinic, drove through a blizzard to Minneapolis and flew here for dinner. That's typical. So Dr. Dolan also, besides all of the work from an operations and clinical leadership perspective, is on the board of the joint UW, Wisconsin, and Gunderson Health Plan, which is a physician-led, health system-owned, and growing health plan in Wisconsin. So with that, I'm going to turn it over to Dr. Dolan, and please do listen closely. I've always found that's always a good idea. Thanks.
Thanks, Bob. So I'm going to start by kind of telling you what I am not. I am not a researcher. I am primarily an administrator. I spend about 60 to 70% of my week, hour by hour, doing administration, running our operations, and managing our clinicians and their practices in the hospital. Gunderson, like some institutions here, Kaiser is one, has a dyad model of leadership. So physician leaders are paired with an administrative leader. So I, as the medical chief operating officer, I have a partner who's an administrative chief operating officer, and together we run the operations of Gunderson Health System. The other thing that I am after that is a clinician. So the rest of my time is spent in clinic, where I have a panel of patients that I've taken care of for about 30 years. And then I also still rotate on the hospital teaching service. So I'm kind of like the old-fashioned internist that still does both clinic and hospital. But I find that doing that allows me a couple of opportunities. One is to actually teach our residents how to take good care of patients and how to approach diagnosis and treatment for people with complicated medical conditions. But then the other thing that it affords me to do is see where the system breaks down. Being able to work on the front lines and take care of patients and see how the system is either working to keep them healthy or not is actually one of the true advantages of being a clinician administrator. And in fact, and what I'm going to talk to you about really was born out of that relationship that I have between administration and clinic. So the title of my talk is something that Hattie's been really bugging me to come out and talk about, and that's really incidental CT findings and its relationship to cardiovascular disease. But I'm going to actually start with a case. And this is one of those cases that, as an administrator, kind of guts you to the core. At the time, I was the medical vice president over emergency services, and as such, I was notified by our risk management that they wanted me to review a patient that had been in the ER. And so I delved into the chart and reviewed the chart. So this was a 32-year-old young man, lived in a small community just outside of La Crosse, and healthy guy, really didn't go to the doctor much. In fact, probably hadn't seen a doctor in about 10 years. And he had come home from work and was kind of roughhousing with his son, who was about 2 years old, on the floor. And while they were kind of playing on the floor, he developed this really unusual chest pain, something he had never had before. It kind of came and went a little bit, and it lasted for about 10 minutes. Eventually got to the point where it was really severe, 10 out of 10, substernal pain that radiated into his jaw and down both arms. He reported that he kind of felt a little sweaty, maybe felt like he couldn't breathe. And so at that point, he talked to his wife a little bit. She said, I think we ought to take you to the emergency room and get you checked out. So he came into the ER. His past medical history was negative. He hadn't been to a doctor in quite a while. He had a family history of heart disease. Both his mother and maternal grandfather had had MIs in their 60s. He was married. He was a half pack per day smoker. He had a long history of dyspepsia due to a pretty high caffeine use. He had some anxiety issues, but other than that, he had had no exertional symptoms, no palpitations, no syncope, no PND, no nausea, no emesis. So on exam, he was pretty normal looking. At this point, he was comfortable. He had no symptoms. Afebrile. His blood pressure was maybe pre-hypertensive, stage 1 hypertension, but nothing alarming. He was satting well. He was in no distress. His exam was really unremarkable. No murmur, rubs, or gallops. No chest wall pain could be elicited. He got an EKG. Pretty much our standard is you get an EKG. If you have chest pain, you get an EKG as soon as you hit the door. He had an EKG, completely normal. Chest x-ray was done, also completely normal. And so, so things looked pretty good. In the ER, the chest x-ray and EKG were obtained. He had this kind of brief episode of chest pain, and he notified the nurse and then did another EKG. That also was normal. He was given a GI cocktail and noted partial improvement in his symptoms. And at that point, the ER physician said, I think we should put you on a medication to decrease the acid in your stomach, and we'd like you to establish with a primary care clinician. And so they told him that, but they didn't actually set him up to see anybody. They just said, you need to make an appointment with a primary care physician. So the rest of the story is that 2 weeks later, this young man still had not made an appointment for a primary care physician, and while at work, suddenly collapsed. He was unable to be resuscitated and died, and never really made it to the hospital to be treated or evaluated. So I read this and was quite dismayed about this story, and I unfortunately we had no information about what exactly he died from, although I had a pretty good idea. So I called the coroner for the county that he lived in, and he had actually requested an autopsy because of the gentleman's young age. And although they don't release the official report, he did say that the patient had pretty significant coronary artery disease at age 32, and that was the approximate cause of his death. So when something like that happens to you, and you really feel like this could have had a better outcome or a better end to this story, it really makes you